All right. So I would like to give a thank you to our community health folks for coming up with this great title of Don't Sweat Menopause. And the funny caricature of the sweating woman who's having a hot flash is only part of what this means. I see a lot of women who fall into the menopause and perimenopausal age range, and I find that the better educated people are, and the more they understand about what they're going through, the easier and more tolerable this natural transition is. So I'm going to take everyone through what to expect, what signs and symptoms are, some treatment options, and try and blow through what could have been a 2-hour lecture in about 45 minutes. So hopefully everyone will get what they need from this. I will see if I can, there we go. All right, so what is menopause, you ask? Menopause is essentially the last menstrual period. It is defined as 1 year of no bleeding. I tell my patients it is a moment in time. It is that point at which you are no longer considered fertile, so birth control is no longer necessary, and any bleeding after that 1 year mark is considered abnormal. And I tell patients it's really perimenopause that most patients have questions about, because that is that transition period from prior to the period stopping through the end of hopefully typical menopausal symptoms. So when does menopause happen? Pretty much almost any age that I have listed here, plus a few more. Average age for menopause in Caucasian American-born women is 51. Obviously, we are not all Caucasian American-born women, so there is some variation. Menopause is considered early if it occurs between 40 and 45, and it is considered premature if it's before the age of 40. Sometimes women will go through menopause prematurely because of surgery. If they have their ovaries removed, for example, they can go through menopause early because of medications, chemotherapy, radiation for cancer are common causes of earlier menopause. So in case you thought you were all on your own, you're not. 6,000 women reach menopause each and every day. And because the life expectancy of women is over 80, most women will spend a third to a half of their lifetime postmenopausal. So you are either premenopausal or postmenopausal, except for that 1 minute when you reach your last menstrual period. So what do women think about menopause? And I actually think it's kind of interesting that they've done surveys to figure out, is it a positive or a negative experience? But what I will tell you is, in my experience, although the studies show that people are neutral or positive in reference to menopause, is a lot of women fear menopause. And as a provider of healthcare and women's healthcare, I think it's important that we help to allay those fears. So let's talk about some signs and symptoms. I once had a patient who brought me a multiple page document because she had Googled the symptoms of menopause, and there were 200, and she was pretty sure she had each and every one. In a moment, I'm going to go through the 3 signs and symptoms of menopause that are medically documented. So obviously skipping periods and hot flashes and night sweats, but if you see on this list, people will complain of weight gain, they'll complain of weight loss, they'll complain of urinary incontinence, they'll complain of difficulty urinating. Lots and lots of symptoms, my favorite being electric shocks. But most of them can be equated back to what happens as a woman is going through menopause. So here are the 3 classic symptoms. Number 1, cessation of menstrual bleeding. We talked about 1 year from no periods. Vasomotor symptoms, that's what everyone knows as hot flashes and night sweats. And then, of course, there's vulvovaginal symptoms and discomfort with intercourse. That's what dyspareunia is. But if you look at those vasomotor symptoms and what they do to a woman, you can extrapolate out a lot of the other symptoms. If you're having night sweats and you're up all night and you're not sleeping well, then you're going to be tired the next day. You may have difficulty concentrating. You might have a shorter fuse. If you've been up sweating for the last 3 nights, you might not want to have sex with your husband because you're tired and you'd rather go to sleep. So a lot of the other symptoms that we hear people complaining of can date back to these 3 classic symptoms. So I mentioned perimenopause. And perimenopause is traditionally thought of as the 3 to 5 years before the final menstrual period. Disturbing to someone who is in the same age range as most perimenopausal women is that now they're saying that this period can last as long as 7 to 10 years. Certainly, certain ethnicities take a longer time in terms of their symptoms. And I always say from the first missed period, the first hot flash or night sweat, until the periods are completely gone and symptoms start to peter down, I usually tell my patients it's about 3 to 5 years. And this is usually the more symptomatic phase of menopause for women, as opposed to once the periods have gone away and symptoms start to go down. So, whoops. All right. I had a pretty picture of a woman wondering what happened to her body, but I skipped it. So let's talk about weight. Everyone thinks that you gain weight when you go through menopause. But the fact is, I say women go through menopause at the most inopportune time in their life because average age is 51, metabolism starts to slow over 40. And over 50, I'll say to my patients, your metabolism kind of hits a brick wall. So if you do exactly what you've done your whole life in terms of diet and exercise, you're probably going to gain weight on average about 5 pounds at midlife. If you put a woman through menopause, either surgically or through medications at a younger age, she usually won't complain so much about weight until she gets to around the age of 50. There are definitely changes in body composition and fat distribution. I always say if you look at the skinniest old lady, she'll have a little bit of a poochy belly. And that's because we tend to put a little bit more fat towards the middle as we get older. There's actually changes in your teeth and changes in your skin that you'll see, a little warning sign that tooth loss, while normally due to tooth decay and poor dental hygiene, has been associated with osteoporosis. So if people start to have dental issues that they had not experienced before, sometimes taking a look for that is helpful. There's a decline in collagen. If you haven't seen enough ads for skincare products, you should know that collagen declines by about 30% in the first 5 years after menopause and declines by 2% every year thereafter. That's why our skin is not quite as tight as it is when we are younger. We have male hormones in addition to female hormones. Our ovaries are primarily estrogen and progesterone dominant, but women have a small amount of male hormones, and the ratio of male to female hormones changes at menopause. And unfortunately, that leads to losing hair where we don't want to on the top of our head and growing hair in places we don't want to, such as on our chin or on our face. I've had people complain of dry eye. I've had people complain of increased tear production. We do know that cataracts occur higher in women than in men of the same age. And in terms of hearing at menopause, there is definitely a rapid age-related decline in hearing in women, although men do have more hearing issues than women. But we do tend to see it more commonly at this point in a woman's life. So, associated health issues. Not all midlife symptoms are from menopause. I'm sorry to say that to the primary care and family doctors who blame everything that a woman complains of on menopause. But we do know at midlife that there is an increase in high blood pressure, high cholesterol, cardiovascular diseases, stroke, diabetes, arthritis, osteoporosis, cancer. You can just go on and on and on and on. Because as you get older, things happen. And so I'm going to highlight 2 of these, the first of which is cardiovascular disease, because cardiovascular disease is the leading cause of death in women. And women tend to develop heart disease later than men. It's not unusual to hear of a 40-year-old man having a heart attack. But for most, in women, it occurs after they go through menopause. And that suggests that there may be a cardioprotective effect of the premenopausal hormones. In fact, when I first started training, women were sent to the gynecologist to be put on estrogen after having a cardiovascular event because it was thought to be cardioprotective. The Women's Health Study, which is almost 20 years old now, seemed to have partially disproved that. But we definitely know that the natural hormones that women have before menopause do play a role, and that when they decline, there's more cardiovascular disease. Women who go through menopause at an earlier age have increased cardiovascular risk. Certain ethnicities, patients who smoke, women who have had less children or shorter menstrual cycle intervals. So if your periods come closer together, you're going to have more periods in a lifetime. And when you're a child or really a fetus, you have X number of eggs left. And when you use them up, you use them up. So women who ovulate more, so they have less children, they have more periods, are going to go through menopause earlier. There is an increased risk of cardiovascular disease. In terms of reducing risks, all the things that hopefully your family doctors are sharing with you, maintaining a good body weight, not smoking, engaging in regular exercise. The DASH diet is the diet approaches to stopping hypertension, but that's essentially more fruits and vegetables, lean proteins, whole grains, less saturated fats, less fatty meats, less full fat dairy. The goal is really to keep cholesterol under 200, blood sugar under 100, and blood pressure under 120/80. And those are all things that help us to fight the increased risk as we get older. The other thing I wanted to touch on was osteoporosis, because that's also very common postmenopausally. And osteoporosis is a disease characterized by low bone density. There we go. Sorry. If you look at the bones on the left, that's what a young person's bone looks like. And you look at the bones on the right, that's what an older osteoporotic bone looks like. So the bone has a structure to it, and there are spaces in the bone. It is porous, but you have to have a good structure to have a strong bone. And when you start to lose that structure and have increased space, it's susceptibility to breaking a bone. So of the 10 million Americans with osteoporosis, 80% are women. And that's because we lose our estrogen after menopause. Male patients have testosterone, and testosterone is their hormone that keeps their bone strong. And although there is some decline with age, not nearly the degree when women go through menopause. You achieve your peak bone mass when you turn 20. And once your estrogen level drops, the bone density really takes a little bit of a plummet. So there's an age-related decline, but then there's a quicker drop off after menopause. And highest risk for osteoporosis is non-Hispanic white women and Asian women. And the way to assess for osteoporosis is by doing a bone density. So bone density, or a DEXA scan, is usually ordered in women 65 and older, or postmenopausal women who have an elevated risk of fracture. So there's certain risk factors, such as a history of a fracture, a low body weight, smokers, excessive drinkers, women with rheumatoid arthritis, all have a higher risk, and then perhaps should be screened at a younger age. There's little value in checking a bone density unless someone is particularly high risk prior to menopause. A lot of people just want a bone density at age 50, and it's not really necessary. So how do we prevent osteoporosis? What do you think I'm going to say? Maintain a healthy weight, eat a balanced diet. Recommendations for calcium. I always say the best calcium you get in the foods that you eat. Dairy, green vegetables primarily, but we're looking at 1,200 to 1,500 milligrams a day. Your average serving, like a cup of yogurt or glass of milk, has 300 to 400 milligrams of calcium. Vitamin D recommendations are usually based on age, although I do tell patients if you live in the Northeast, where if you look outside, like I'm looking out the window, it's gray and cloudy, we get our vitamin D from the sun. And in the summer, when it's sunny, we put our sunscreen on so we don't get skin cancer. So I usually recommend 1,000 units a day for vitamin D. We're checking a vitamin D level. Exercise keeps your bones strong. When your muscles pull on your bones, it keeps them remodeling and laying new bone on. Avoid excess alcohol, don't smoke, and please try not to fall. Lots of different choices for treating osteoporosis. Women who've had any type of fracture, regardless of their bone density result, unless it's traumatic, like an accident, like a motor vehicle accident or a skiing accident. But if you twist your ankle on the curb and you break your foot, you probably need to be on medication. T-scores are how they value bone density, and a score of 2.5 is osteoporosis, so that should be treated. And there's actually something called a fracture risk calculation that can be done in a woman who has osteopenia, which is a precursor to osteoporosis. And if your risk is over 20% for a fracture in the next 10 years, or only 3% for a hip fracture, because that can be life-altering, then treatment is recommended. Many approved medications, that's a whole nother talk for a whole nother day, but it should be based on the individual, various side effects, and physician recommendation. So let's get back to our perimenopausal symptoms. First of all, changes in bleeding profile. Believe it or not, most patients don't just stop their periods one day. And as much as we'd like to think that they would just space out and get shorter and lighter, a lot of women actually will find that their cycle length, which is the cycle interval, which is the time between periods, gets closer, their period length gets longer, and their periods get heavier. And I call that the storm before the calm. So as your hormones decline, both estrogen and progesterone go down, and progesterone is the hormone that tells our bodies when to bleed and when to stop bleeding. We tell women in the premenopausal age range, periods can range anywhere from 21 to 90 days, although average is between 21 and 35. But once you get to the perimenopausal time range, you can miss months and months, and then you can get your period back for months. So I always say periods should be no longer than 7 to 10 days in duration. You should not have bleeding between your periods, and you should not be soaking those tampons in pads every hour on the hour for more than, say, 6 to 8 hours in a row. That could be significant bleeding. Eventually, what will happen is periods will space out, they'll get lighter, and the last couple of periods before a woman goes through menopause can be as little as a day or two of spotting. So it's important to keep that calendar, that period app, because you will get your period at 11 and a half months, I'm sorry to say, and you need to count a whole nother year to be considered menopausal. But it is helpful that if you come in with abnormal bleeding, that you know when the last time you bled was. Vasomotor symptoms, those are your hot flashes and night sweats. The technical definition is recurrent transient episodes of flushing accompanied by a sensation of warm, intense heat, usually in the upper body, face, or head. Although you'll get people who will say they sweat at their elbows, they sweat behind their knees. It is most intense during the perimenopausal period. 70 to 80% of women get hot flashes. And if you're in that 25% that don't tell your friends. Symptoms can be severe in 10 to 15% of women. There will be women who have multiple hot flashes over the course of an hour. They'll be up all night without sleeping because they're flashing. That's where that 3 to 5 years comes in. There are 70 and 80-year-olds who still have hot flashes, but on average, most women are symptomatic for 3 to 5 years. And certainly for those that do have them for longer, they do tend to decrease in frequency and intensity over time. If you are a smoker, smokers tend to have more and worse hot flashes. So what causes a hot flash? If I knew, I wouldn't be giving this talk. I'd be living on a private island, and people would be coming to me for the secret of the hot flash. But the way I explain it to people is there's something called the thermoneutral zone. It's a point in of heat in our body where we don't feel hot and we don't feel cold. And anything that triggers a rise above that thermoneutral zone will cause sweating or cause a hot flash. So when you're 25 and you have 105 fever, you will be sweating and having a hot flash. But when you're 50, that thermoneutral zone is so tiny that anything that heats you up is going to make you flash. And then often you'll get shivering once the hot flash is over because your temperature falls below that thermoneutral zone. So what can we do to try and limit? There's contributing factors: warm environment, hot drinks. The big ones I point out are spicy foods, alcohol, stress. And I would say what you can control, you should control and or limit, and what you can't control, because certainly we all have stresses we can't control, you just do your best to learn how to cope with that. There's medications and disease processes that can contribute to hot flashes, and no value in checking hormone levels because there's never been any correlation between where your estrogen is and whether you're flashing or not. Treating vasomotor symptoms depends on how severe they are, what a woman's risk factors are, her personal preferences. There's many hormonal therapies available and many non-hormonal therapies that are available. So estrogen is the key to stopping the symptoms. Unopposed estrogen is only prescribed to women who do not have a uterus. So those are women who've had a hysterectomy. If a woman has a uterus, progesterone is added to protect the uterine lining from the estrogen and the risk of uterine cancer. Bioidentical hormones are a hot topic. They've been around for a long time, and there are some that are FDA approved and tested and available by prescription. And then there's those that are unapproved and untested and formulated at compounding pharmacies. Almost all forms of estrogen, there's oral ones, there's transdermal, which is like patches and creams. There's even a vaginal estrogen that has systemic use, are approved for the treatment of moderate to severe vasomotor symptoms. Okay. We talked about briefly, I mentioned the Women's Health Study, which was the study that was actually looking at the benefits of estrogen and ended up finding some risks associated with estrogen use. And once that study was brought to fruition, the FDA created a black box warning for any estrogen or progesterone, including risks of cardiovascular disease, endometrial cancer, breast cancer, and probably dementia. Now, there were only 2 hormones used in the Women's Health Study, but we always tell patients that the risk can be extrapolated to all hormonal therapies, as well as the natural or bioidentical hormone therapies. So it's a great treatment. We'll go through the risks in a minute. In addition, although you can't claim that it has been approved for enhancing quality of life, if you think of the woman who's suffering from lack of sleep and very disruptive hot flashes, obviously treating it will improve quality of life. Hormone therapy has also been shown to reduce fracture risk in postmenopausal women, although it has never been FDA approved for treating osteoporosis. In terms of cardiovascular risk, it is actually believed that when you start hormone replacement at a younger age, closer to menopause, you may have some cardiac protective effects. So the Women's Health Study took women from 50 to 79 years old and put them all on the same doses of estrogen and progesterone. And so a 50-year-old who's just going through menopause is a different beast than a 79-year-old who may already have some heart disease, have high cholesterol, high blood pressure, age-related risk factors. So after the study concluded, and actually concluded earlier than the set date because of the increased risk, they looked back at the different demographics and the age ranges. And at this point, we actually tell women that if you start your hormones close to menopause, you're probably not going to have increased cardiovascular risk. So it is not approved for protection against cardiovascular disease. It is not contraindicated. There has also been in the study a possible reduction in diabetes, but again, not approved for that purpose. So what are the risk of taking hormone replacement. First is the increased risk of stroke or blood clots, what we call DVT, which is a blood clot in the leg. Stroke, it's the type of strokes where you get a blood clot, not a bleed in the brain. The risk is greatest when you first initiated and declines over time. In terms of breast cancer, which is something women are very fearful of, the estrogen alone arm of the women's health study actually showed no increased risk and a decreased risk with estrogen after 7 years of use. Whereas when you took estrogen and progesterone together beyond 3 to 5 years, there was thought to be some increased risk of breast cancer. And so that went away when you stopped it. So again, the whole concept is you start hormone replacement in those who need it. You start it earlier to reduce your risk, and you use it for the least amount of time and the lowest dose needed. No data for ovarian cancer. In terms of cognitive function, we actually thought that hormones would be good in terms of dementia, but the memory study portion of the women's health study actually showed an increased dementia in the older population, 65 to 79-year-olds. And this is a sad saga that estrogen and progesterone actually increases urinary incontinence. So we're going to talk about incontinence a little bit at the end of the talk, but our kind of theory that estrogen in the vagina is what helps lower the risk of incontinence, not so much. Just want to touch briefly on bioidentical hormones because they are very commonly used or requested at this point in time. I did mention that some are formulated for use by and tested by the FDA, but the ones that are compounded at compounding pharmacies, and they are not tested for efficacy. They do not have to go through the FDA. They are kind of marketed as supplements, not as medications. And there's no standardization on purity or dosing. And so I'm a big anti-pellet girl. Pellets are injected and they last for 3 to 6 months and are not reversible. So once the pellet is in your body, you cannot remove it or counteract it. So if you get diagnosed with breast cancer that is hormonally sensitive, a month after you get a hormone pellet, it could take up to a year for your hormone levels to decline again, and that can have effects. So if patients need hormone replacement, I think it's really important they speak to their doctor, that they have a conversation about, essentially what we're looking to treat, what the risks and benefits are, and then make a decision for an FDA-approved drug. There is some data that using a transdermal or through the skin means of giving estrogen is better than oral. When you take medicines orally, they go from your GI tract into your liver, and then they get placed into the bloodstream. When you put a patch or rubber cream on your skin, it goes directly into the bloodstream and then goes through the liver, what we call second pass. And particularly for cardiovascular risk, cholesterol and lipids, transdermal use is probably safer. The progesterones are usually given orally. So just a takeaway, the goal is no more than 3 to 5 years if you're using estrogen and progesterone. I mentioned lowest dose, shortest amount of time, potential benefits of using it earlier. And beyond that 3 to 5 year time frame, doctors have to talk to their patients. You have to weigh the pros and cons. There are some patients who just feel so much better and they don't want to stop. And you review family history, you review risk factors, and it is perfectly reasonable to continue beyond 3 to 5 years as long as women are aware of their risk. When you stop your hormone replacement, 50% of women will get vasomotor symptoms returning. And I personally believe if you take the doses down slowly and you wean, it's better tolerated, although data shows the symptom recurrence is regardless of whether you taper or stop abruptly. So now we're going to talk about some non-hormonal treatments. Some patients may not want to take estrogen, or they have a reason not to, a hormonally sensitive cancer, significant family history of blood clots and such. So we have prescription treatments that are non-hormonal, and the medications that fall into our antidepressant, anti-anxiety family have been shown to have up to a 60% reduction in hot flashes. So that is often very helpful. It also sometimes helps with sleep. Sleep aids, whether they be prescription sleep aids or over-the-counter sleep aids, help. I tell my patients sometimes just a Tylenol PM or a Unisom if you've had a couple really rough nights of night sweats and you haven't slept, you'll get that antihistamine, dry mouth, when you wake up, but you'll get that drug sleep such that you might have some night sweats, but you'll fall back asleep. And you'll wake up and your pillow will be damp and your hair will be wet, but you will have gotten a good night's sleep. And it often helps you fall asleep better the day or two after. Once you get, it becomes a vicious cycle of not sleeping and worrying about not sleeping. And then you wake up and you get your busy brain going. There's one anti-seizure medication. There's one hypertensive or blood pressure medication that have also been shown to reduce hot flashes. For non-hormonal treatments, things that are over the counter or other things that you can do, soy helps reduce hot flashes. Vitamin E helps reduce hot flashes. There are many herbal remedies, acupuncture, meditation, and mindfulness does help. If you're having a hot flash, you can take two approaches to it. You can get upset, your heart can race, you can feel miserable, or you can kind of close your eyes and try and breathe your way through it, and it probably will go away quicker and be less intense. There are topical over-the-counter products, dietary supplements, and then things like melatonin or herbal sleep aids that help. I tell my patients, in terms of herbs, there's a lot of products out there like Remifemin and Estrogen that have some soy, they have some vitamin E, they have some black cohosh in them. Any supplements you take should be reported to your doctors under the medication list of things that you're taking, because there are things that can interfere with other medications. They can cause bleeding if you have surgery. Many products are very safe to use, but you do want to make sure that they're not interfering with any of the other medical things that you're doing. The studies that have been done on all of these complementary and alternative medicine choices have shown no statistical improvement in their symptoms. However, a significant number of patients swear by them. There's a lot of studies that have been done comparing to placebo, but there's something called the placebo effect. So if I gave you a pill and told you it would help your hot flashes, you have a 30% chance your hot flashes are going to improve or decrease in intensity. And I think for a lot of women suffering with symptoms, 30% sounds pretty good. And so I wouldn't shy away from them just because there are no studies. I recommend these to women on a daily basis. And then we're back to lifestyle modification. I wouldn't be a good doctor if I didn't tell you to eat right and exercise regularly, avoid hot flash triggers, dressing to keep cool, dress in layers, dress in light cotton, breathable fabrics. A tank top with a cardigan is way better than a long sleeve shirt with a pullover sweater. There's special pillowcases and things that help to keep the room cool, cooler drinks. I talked about meditation and yoga and breathing exercises. We're going to get to sex in a minute, so we'll skip over that last point. So there's a lovely new term called genitourinary syndrome of menopause. And you see the Sahara Desert. It's probably not the Sahara Desert, but it is a desert, and that's the way a lot of postmenopausal women describe their vagina. So GSM for short includes vaginal dryness, vaginal burning and irritation, lack of lubrication, pain with intercourse, urinary urgency and frequency, pain with urination, and recurrent urinary tract infections. to name a few of the symptoms. So in terms of what happens to vaginas and what happens to your sex life during menopause, first of all, libido in general decreases with age. And whether that's from declining hormones or life circumstances, I don't think you can blame either or omit either one of them. Midlife is a common time for patients to complain about distressing sexual problems, but over the age of 65 is when people have the least complaints. When you lose estrogen, you lose the moisture in the vagina and you lose the elasticity in the vagina. I mentioned that women produce a small amount of androgens or male hormones, and male hormones contribute to our libido or our desire to have intercourse. So decline in androgens has an effect as well, both desire, arousal, lubrication. We tell women it takes longer to become aroused. Climaxes are not as intense as they are when you're younger. And sometimes women have issues even climaxing at all. Having regular sexual activity using lubricants does help to keep the tissue more moist and elastic. And we'll talk about some other treatment options in a moment. In reference to hormone replacement, and first I'm going to talk about what we call systemic hormone replacement, which is what we talked about, oral or transdermal estrogen and progesterone. It may or may not improve sexual desire. Now, if sexual desire comes from dryness and discomfort, or the decline in desire comes from having hot sweats and hot flashes and night sweats and being miserable at night and not wanting to think about having sex, then fixing those symptoms, of course, is going to help. I talk about vaginal dryness. I call it the disincentive program. So if you have sex and it is dry and it hurts and it doesn't feel good, why in the world would you want to have sex again, right? So what we do as physicians is when a patient comes in and says, my sex drive is, really taking a tank, the first question I have is, how is sex? How does it feel? When you bother to do it, or do you get pleasure out of it? Is it uncomfortable? We do know that when women use hormone replacement, it does help their dryness. It does enhance skin sensation. It does increase lubrication and elasticity. In a moment, we're going to talk about vaginal estrogen products, which often do the same thing without having the systemic effect of the estrogen. So if someone's not having a lot of vasomotor symptoms, you can treat the problem locally. So we're not going to go into too much of the details in terms of what actually happens to the tissues in the vagina, although I have a pretty good slide to explain it, but there is definitely more inflammation. The pH changes from an acidic environment to a more basic environment, and irritation, itching, dryness happens in, I would have to say, more than 10 to 40% of menopausal women. It's probably more than half. Whereas the vasomotor symptoms get better with time, vaginal atrophy tends to get worse because the longer your vagina goes without estrogen, the crankier it becomes. Treatments include regular sexual activity, use of lubricants and moisturizers, use of sexual stimulators like vibrators, and the use of vaginal estrogen. So first, non-hormonal, and I'm not advertising, but I couldn't find a picture of a lubricant bottle without a name on it. But we always recommend that the first line of defense is vaginal lubricants and moisturizers. Moisturizers you can use on a regular basis. Lubricants are used specifically for intercourse. We always recommend a water-based lubricant first. Our bodies are made up primarily of water, so a water-based lubricant is going to be absorbed into our bodies. The problem with some water-based lubricants is they don't last very long. So if I always say you put a little bit on your partner, you put a little bit on your vagina, it often helps with penetration, which is one of the most common discomforts that women have. But if intercourse takes a little bit longer, sometimes the lubricant kind of dries up. So there are also silicone-based lubricants. They're a little slipperier, they last a little longer. And to me, they meet a need that sometimes the water-based lubricants do not. So I don't get really obsessed with the fact that it should be water-based. There are some hyaluronic acid products that are specifically for vaginal dryness. So you cannot put your oil of Olay for your face down on your vagina, but you can Google hyaluronic acid for the vagina, and it is really, again, used more as a moisturizer. The concept is to really soothe the tissues that are a little bit more delicate. We talked about, I mentioned vibrators and self-stimulation to kind of move along the process to help patients become aroused. And in terms of the sensitivity of the skin, I even tell patients, you don't need to use soap in the vaginal area. If you have a shower head that comes down with the water, or just a gentle washcloth with water is enough to clean the vagina, because particularly fragrant skincare products can be very irritating to postmenopausal women. So we are not talking about cell layers or any of the crazy things that I would give in a lecture to other physicians, but on the left is a premenopausal vagina, and on the right is a postmenopausal vagina. Thicker layers of cells, more ridges and folds. So this is the description I give to my patients. When you're premenopausal, your vagina is like a pleated skirt. It has ridges and folds, and it moves. And when you're postmenopausal, your vagina is like a pencil skirt. It becomes this stiff, non-yielding area. So whole babies come out of vaginas when we give birth. We have ridges and folds. You saw the previous picture where the vagina has, we call them rugae. They belong there. They let the vagina stretch and expand and then go back to normal. And after menopause, as you lose the blood supply and you lose the hormones to the vagina, the tissues get thinner, they get less pliable, the ridges go away. So ladies, the only place you want to have wrinkles is in your vagina, okay? So how do we return the wrinkles to the vagina? If you ignore my picture of the laser in the middle, there's many different hormonal treatments of vaginal atrophy, from creams to tablets to suppositories to vaginal rings. And what vaginal estrogen does, as I mentioned, is it puts the product where we need it. And it restores the pH of the vagina. It helps to thicken up those superficial cells, and it helps to return some blood flow to the area. So women who use estrogen find that you probably still need a lubricant because it'll help lubrication, but not quite as much. But their skin is less sensitive. They become aroused easier, and they find it to be much more comfortable. If you're more comfortable, then you're motivated to have sex more often. And just by having sex, you are stretching those tissues and making them more responsive. There is a product which is a selective estrogen receptor modulator. It is an oral product that is taken daily. It's called Ospemifene. There is also a androgen that is given vaginally, and they consider themselves the non-estrogen treatment of vaginal dryness. What I will tell you is, in terms of the Ospemifene and the androgen, is they need a little bit more studies in terms of breast cancer related risk. There are patients who take estrogen receptor modulators, for example, to block estrogen for breast cancer. And if the Ospemifene interacts with those modulators, it could perhaps decrease the effectiveness of those products. The most important thing I tell my patients about vaginal estrogen is that it has minimal absorption into the bloodstream. So it is considered safe for patients who would otherwise not want to use an oral or a transdermal estrogen, because you get the effects locally without the systemic effects. I showed a picture of a laser, and there are a number of products out there. One of the better known ones is called the Mona Lisa laser. And by some very hard to understand engineering, essentially by putting little pulses of laser into the tissues, which you would think would cause damage to them, it causes them to restructure and become healthier. And so for patients who do not want to use any of the other treatments, it is a treatment option. It's usually a set of 3 treatments followed by yearly touch-ups, as they call it. And it is under evaluation now for approval, like via the FDA and such, for treatment of vaginal dryness. And specifically discomfort with intercourse. So I promised a quick touch on urinary symptoms. The sad story of the Women's Health Study was that systemic estrogen might actually increase incontinence. Urinary complaints are very common in women, and we certainly see them at all ages, but they are more common as women get older. So as with anything, was it the age range of the women in the study that showed more incontinence because they were getting older, or was it the estrogen that caused it? The good news is that the vaginal estrogen products have actually been shown to improve urgency and what we call overactive bladder. Those are the TV commercials where the woman says, I gotta go right now. We also see more urinary tract infections in postmenopausal women because of the changes in the tissue. Urinary tract infections are usually caused by bacteria from the vagina and the perianal area getting into the urinary tract, often during intercourse. So if you plump up those tissues and you create a thicker barrier to the bacteria getting in, you can lower urinary tract infections. It is not government approved for this purpose, but it is certainly believed to help in that way. So we've hit a lot of topics here. Most important take home is that menopause is a normal, natural event in a woman's life. Average age is 51. You can expect symptoms for 3 to 10 years, including changes in menstrual cycle, hot flashes and night sweats, and vulval vaginal symptoms. Many health associated issues at midlife that are not necessarily due to menopause, but many of our lifestyle things that we do to keep ourselves healthy can reduce our risks and reduce our symptoms. And the most important thing is not to sweat your menopause, to become educated, to understand what's going on with your body, to have a conversation with your doctor, and to help you get through this natural phase of life with the least bumps in the road getting there. And that's all I got.
I think we have a lot of questions, which is good. And I also just want to do another plug for the evaluation. Again, I put it into the chat box. If you can complete that before we leave tonight, you could do it during questions or after questions, that's fine. And I will stay around for a while to, as they come in, so that, we can receive the evaluations. Also, again, the recording link will be in the chat box as well. So Dr. Schwartz, you want to read off the, I think they all went to everyone, so I think we should be good.
Okay. I mean, so you did talk about sharing the presentation, and someone asked what excessive alcohol consumption is for postmenopausal women. It is not necessarily different for pre or peri or postmenopausal. I ask every woman how much alcohol they have. Do they drink daily? Do they drink just socially on the weekends? And I always say to my patients who have 1 or 2 glasses of wine with dinner every night, if you lived in Europe, that would be expected of you. But in general, what I tell patients is for many different health reasons, not just menopausal symptoms, women should really not have more than 1 alcoholic beverage a day. And I have one lady who tells me if she has 1 glass of wine, she's fine. If she has 2, she has hot flashes. So in particular, relative to menopause, you probably want to see what you tolerate. And, there's other increased risk associated with alcohol consumption, including increased breast cancer risk and such. So I was told by a nurse that calcium can increase cancer risk. How do you know that? So there have been studies that showed an increased risk of heart disease with calcium. Those studies were done in men, not women. There are no studies that I know of, although I'm not an expert in the field, about calcium and cancer. I always say to patients, the best calcium you get from your diet. And of course, we're also at the same time watching our cholesterol and watching our fat intake. Although I tell patients skim milk and low-fat cheese has the same benefit as, if not more calcium than full fat. So what I would tell you is, try to eat a calcium-rich diet. It is, unless you're a milk drinker, and what I didn't mention is there are a lot of our other non-dairy products such as soy milk and almond milk that are also very rich in calcium. So read your labels. When you read a label, it's going to give you the percent recommended daily allowance, which for a 21-year-old man is 1,000 milligrams a day. And that's where most statistics come from. So if something has 20% of the recommended daily allowance, you're getting 200 milligrams. So keep a little calcium survey and look what you're getting in an average week. And it's hard to meet that 1,500. So premenopausally, 1,000 is plenty, 3 servings a day. Postmenopausally, sometimes you'll need to get a calcium supplement. And then I would just ask whoever told you that calcium causes cancer for the data that shows that. There is no one perfect supplement for everybody. I have a whole handout that I give my patients that has some resources and some lists. Classically, the things that people find the best for hot flashes and night sweats are soy, vitamin E, and black cohosh is a component of a lot of the over-the-counter remedies. There are certainly some other herbals, and there are some good resources online where you can see what helps with that. Anyone coming in my office gets my menopause handout. I don't know if there's a way for me to get it to Marsha that she could post it for people to have. Hot flashes and cold flashes. Yep. Most people get either hot or cold. Much smaller percent get cold flashes than hot flashes, but commonly after you get the hot flash, as your body temperature drops, it goes below that thermoneutral zone, and then you'll get cold and get the shivers. People get them daytime, people get them nighttime. And like I said, we wish we knew what made one person get terrible flashes and someone else get none, but we really don't understand that. So this person is always hot and sweating, freezes her family out, and has not yet gone through menopause. I'm very sorry for you. There are women who get hot flashes 10 years before they ever go through menopause. What I would tell you is if you're having symptoms and you're getting your period every single month and you have no other symptoms related to menopause, it wouldn't hurt to see your family doctor, get your thyroid checked, get some other blood work to make sure there's no other cause of the sweating. And I have the shower's a classic one because you want to, as much as I love my hot shower, you got to turn that heat down a little bit. I tell patients, take that hair dryer, put it on cool, blow dry your face, cools you off after the shower. The person who says they're hot all the time is different than the true hot flash. I'm sitting in a room that's freezing. My hands are like ice cubes, but out of nowhere, the heat will rise. 30 seconds, a minute later, it'll go away. You might be clammy, you might be shivery, and then it goes away after that. Weight is a big component. Smoking's a big component. Women who are heavier tend to sweat more. Women who smoke actually eat up their estrogen quicker. They go through menopause earlier, and they definitely have more symptoms. So bioidentical hormones, what I call holistic is pretty much anything that's non-medicinal, non-prescription. So your herbals, your vitamins, lifestyle modification are all holistic options. Bioidentical, people will often call them natural hormones. Women have 3 different estrogens that we produce from our ovaries. The biggest component is estradiol, which is what's in most prescribed hormone replacement options. So the concept of bioidentical hormones is to kind of mimic what our own body produces. And the problem is that most pharmaceutical companies do not, they choose one component of estrogen, not the others. The point is to fix the symptoms, not necessarily to try and have the hormones of a 30-year-old in your body. There are numerous products, for example, plant-based progesterones are the most common progesterones that are prescribed by prescription, and those are considered bioidentical too, or natural as well. So as I said, the patient who goes in and the pharmacy puts a little bit of estradiol and a little bit of estrogen, and they swirl it together with some more testosterone, and we don't really have a set dosing there. That's where the danger comes in. So one person said that the cooling sheets and pillows did not help. Olive oil, coconut oil for the vagina, awesome. You can go out and buy lubricants in the pharmacy, and I always say you can use natural. I always say just don't choose oils that have a smell to them. And be aware that oils can stain sheets. So, but absolutely, a lot of women will use mineral oil or vitamin E externally as a moisturizer, and that helps. And a lot of people turn to coconut oil as a big one that can be used as a moisturizer during intercourse. Another coconut oil comment. I'm sorry, I skipped through some pages because I thought the talk was too long. So let's rock that pencil skirt. Thank you. Someone mentioned taking gabapentin for restless leg. Is it safe to be used on a regular basis? I would talk to the person who prescribed the gabapentin, but there's plenty of people who do use it regularly. And if it helps your hot flashes, you should use it for the time frame that you need to until you feel like you have kind of gone through that transition. So someone said, I thought soy was bad. So there's good soy and bad soy. You have to have a little bit of caution with soy because it can have some estrogenic effects. So soy in food is very safe. Certain soys that you find in menopausal supplements have also been found to be safe and to not have estrogenic effects. So we just caution patients with estrogen sensitive tumors in terms of excessive soy consumption. So I always say some tofu, some soy cheese, some soy milk will often help. Again, remember, there were no statistically significant studies showing that it helped, but it's on my list of things that I recommend that people try. And if it helps, it helps. If it doesn't, it doesn't. All right. Someone asked about stopping birth control pills. She's 46. So everyone is different. There are some doctors there are certain contraindications to birth control pills over the age of 35. That includes smoking, high blood pressure, and obesity. Some doctors stop everyone at 50. There is blood work that can be done to assess whether a woman is menopausal or perimenopausal. That can help making that decision. And I don't have an issue with my patients who have low cardiovascular risk staying on birth control pills until they are fully menopausal. I will ask them, most commonly they'll have symptoms. If they're getting hot flashes and night sweats, they'll see them during their placebo week because that's when you're not getting your hormones. And so a patient comes in and starts saying, hey, I'm having hot flashes during my period. That's a hint to perhaps check the blood work before the age of 50. All right.
Doctor, I have one that just came directly to me. That was next. After stopping HRT, the hot flashes have returned. As you said, how long will that last? I feel like I'm starting symptoms of menopausal over again.
I'm so sorry. um, so yeah, there's some people who say you should not go on hormones because all you're doing is delaying the inevitable. That is not where I come from. I think that when symptoms are not tolerable, you treat them, and that's why I'm a weaner of hormones. I lower the dose, lower the dose, lower the dose until I get to the lowest. I go to every other day, or if I'm using a patch, I leave the patch on longer. And then at each step, often women will have symptoms. So I make changes very slowly, 6 weeks to 3 months. Wait till you feel better, lower your dose again, wait till you feel better. It sounds like Chinese water torture, but it actually, when you make that last step down, I think it's better tolerated. So the question is it going to last the same 3 to 5 years? I hope not, but everyone is different in terms of how they tolerate. And I often will reintroduce the same holistic treatments that I started with patients before they went on hormones. I say, okay, you may want to go back and try the vitamin E again and try other things again. There was one other question that I saw. Someone got cardiomyopathy from her hormone replacement, and really it's coronary disease, heart attack, atherosclerosis, and stroke that are most commonly associated with hormone replacement. Cardiomyopathy actually is a common thing that we'll also see postpartum in women, and so it may have a hormonal relationship, but that would be something to discuss with the cardiologist because I'm not as well versed on that. And then someone asked about bleeding. What happens if you bleed with hormones? So the key is the 1 year of no bleeding. You are menopausal, and for the person who asked, you no longer need contraception. If you go on hormone replacement with estrogen and progesterone, one of the side effects initially is that you can bleed. That does not mean that's your period. That's bleeding in response to the hormones. You should always report it to your physician, and they will decide whether it needs evaluation or not, but it does not mean that you have to go back to contracepting. Once you're at menopause, you're at menopause. And there are ways to give hormone replacement in a cyclic fashion, almost like a birth control pill, where women will menstruate monthly. Again, it's not a period. It's bleeding because of the hormone replacement. We tend to do that in women who need treatment early on while they're still having their periods. Most of the time, women take estrogen and progesterone daily. And after a little adjustment period, they should not have bleeding. So if you do bleed, you should discuss that with your physician. I think, Marcia, I think I hit them all.
It says, do some women have hot flashes after menopause, and for how long? Did you answer that?
Well, so we talked about women can have hot flashes for 10 years before their periods ever stop. Most women have hot flashes in that 3 to 5 year range. Now they're saying 7 to 10 years. I have an 80-year-old lady who tells me she gets a hot flash probably once a month and it makes her feel young. God bless her, because I would rather feel young in another way. But that being said, yes, you can have hot flashes for many years postmenopausally. In general, they become further apart, they become less disruptive. And it's for those who really find it to be very disruptive that's when they have to have their conversation with their physician about what the options are for management. And I'm getting lots of thank yous. So thank you guys for listening to me. I know I went a little bit long. I do only gynecology, and I'm assuming all of you out there are who I see on a daily basis, because I've been doing this for 26 years now. And so everyone who came to see me when they were 20 is 46, and everyone who came to see me when they were 40 is now 66. And so as I mentioned that, Marcia mentioned in my bio, when you do this for a long time, you take women through all these different stages of their life. And all my ladies used to say to me, "Oh, Dr. Schwartz, wait till you go through menopause." And I figured, for all the hot flashes and night sweats and all the dry vaginas I talk to people about, I should get a get out of jail free card. But it is a natural thing. And as I said, the better educated women are, I think the better understanding and the better tolerated this process is for people. So I hope everyone found it helpful.